So I'd like to thank AIOS and ASRS for this opportunity. So let me start why it all began. We were always curious to use the human amniotic membrane or the ham in challenging macular cases. I tried it a couple of times but found it very difficult to handle. So what were the problems faced? Number one, visualization. It's translucent and thin. It's difficult to visualize extraocularly and even intraocularly in high myopes. So you can lose the graph because it's translucent and difficult to see. Sizing. So we tried to size it using Vanna's forceps initially. Then we tried sizing in the eye using the curved scissors. I found it very messy and non-elegant. So the optimal size was a challenge. Third was placement. So chorion side, which is supposed to go down, is very sticky. So we found it used to keep on sticking to the forceps. And then you're trying to remove it from the other forceps, it gets stuck there. So then it becomes like a very messy kind of a maneuver in the vitreous cavity. So this was the reason why we were not using it much. And the other thing is shoving it into the hole also. I thought that if you are pushing it with sharp forceps, you're going to cause a lot of RP damage. So we discussed this with my friend Dr. Dilraj, who was one of the pioneers of the neurosensory graft, and we planned a workaround for each step. So there's a fun video which we've made, which I'll share it with you, so you can enjoy the video. And it's a little humorous also, so something to wake you all up. So you can start a video, audio is there. Audio.
Surgical toolkit for ham grafting in VR surgery. Dr. Rizzo's group recently described the brilliant concept of human amniotic membrane or ham grafting for recurrent macular holes. However, there's hesitancy in adopting this technique due to difficulty in visualizing, handling, and placing the graft.
Hi guys, hope you're well. So I am going to hold your hand through preparing, making, and roasting the most amazing Christmas roast ham.
Let us guide you through our recipe for ham in VR surgery. We depict a surgical toolkit using 3 S's: staining, sizing, and sliding. First S, staining. It is true that the amniotic membrane is indeed difficult to see. It is white, translucent, and thin. Simply staining it with a few drops of brilliant blue dye solves the problem. Second S, sizing. We need to determine the graft size and then cut it neatly and accurately. We use inexpensive disposable dermal trephines. We measure the macular hole indices preoperatively on OCT B scan. After some trial and error, we found that the optimal graft size is roughly the average of the sum of the minimum linear diameter and the base diameter. See how easy it is to get the perfectly sized graft with a dermal trephine. Third S, sliding. Accurately and atraumatically placing the ham graft is a major challenge. We use a bimanual sliding technique with a Tano brush and a nitinol flexible loop. Let's see a few cases. This 62-year-old lady presented with failed macular hole surgery done 2 months ago. See how nicely the graft slides in with the bimanual technique using a Tano brush and a finesse loop. Post-operatively, the hole is closed. This RD case came post-operatively with an attached retina but had developed a macular hole and oil emulsification. We did a silicone oil removal and bimanually placed a ham graft into the macular hole. See how beautifully the hole has closed. This was a failed macular hole case who developed a total retinal detachment with vitreous hemorrhage. In such cases, we place the graft under PFO or after fluid air exchange. You can see how we bimanually slide and spread the graft and place it accurately under PFO. Post-operative OCT shows that the retina is attached and the macular hole is closed. This was a very high myope with a posterior pole retinal detachment and a macular hole. In this case, we slid in the ham after fluid air exchange. In such cases, we take the graft size to be twice the MLD. See how scary the pre-op OCT was and how nicely the retina is settled with a ham graft.
Look at this. I mean, luscious. There is no more festive sight than a glazed ham.
With the Triple S technique, we provide you with a toolkit and our recipe for the perfect ham graft in VR surgery.
So this was the amniotic membrane. Just a little bit about neurosensory graft. So if the hole is in detached retina and availability of ILM is an issue, this is where we sometimes use this technique. Just one case to elicit this. This is a patient who had vitrectomy with oil, developed a ERM, at that time had a ERM plus ILM peeling for the pucker. So the patient was referred to us with a recurrent RD. You can see the MH with RD. And this is the video. So this was the area where we are going to take the graft. I prefer to use scissors rather than the cutter because the scissors are more controlled. And then we cut it till we have a little bit still attached so that it doesn't fly off. And then the idea is to put a PFCL bubble which kind of covers this and then drag it under this over the macular hole. So I think this. So now position over the hole, and here the finesse loop is very gentle and I feel it's atraumatic. Then we do a fluided exchange and put the oil. And this was post-operative. You can see it looks pretty nice. Graft seems to be integrated and patient is from hand movement 6/60, retina is well attached. So my kind of a rough algorithm is if the ILM graft, I always prefer to use ILM and inverted ILM for primary cases. Never use any of these for primary cases. But if the hole is small, less than 1000 micron, I mean this is what we define as small right now. So we do a ILM graft technique. I do a neurosensory retina for macular holes with RD, which minimal PVR or no PVR. But I use an amniotic for large failed macular holes with attached retina because I don't want to really cut the retina when it's attached. So I prefer the AMG. Pediatrics, I don't want to cut retina unnecessarily, or very complicated high myopes sometimes because we don't want a very long cases the case to go on too long because of risk of choroidals and the challenge in these long eyes. Thank you.
Thank you, Dharaj, for the excellent presentation and very nice video. Thank you. Any question from the audience?
What was the instrument that you used to slide the amniotic membrane graft inside the eye?
So I use a bimanual technique. I don't know why. You can use two tanos or two finesse, but I like to use in the right hand a finesse loop and left hand tano brush. I think that works very well because with the left hand you kind of anchor it, so you need something firmer. So I find the tano is firmer, and the finesse, it's more flexible. So that helps you tuck it in. So because I'm right-handed, so I suppose if you're left-handed you can reverse it.
No, she's asking how do you insert it inside the eye?
To take it inside is not
Yes,
regular forceps, any
regular
intravitreal
forceps.
forceps. But once you take it inside and rest it on the retina, then I don't like to push it in using forceps. I like to slide it in with these instruments.
So you use the ILM peeling forceps and grasping to take it inside?
Regular.
Regular
peeling
ILM
forceps
peeling.
or whatever, end gripping.
But you
whatever
don't
have it
prefer to
handy.
slide it under the PFCL bubble. You don't insert PFCL in these cases,
No,
unlike
no,
the
no.
retinal autograft.
No, in retina autograft, we put PFCL. In the AMG, no PFCL.
Why?
Under
Does it
eye.
make it more slippery or why?
You don't need it.
You don't
You don't need it.
It does not slip off.
It doesn't slip off, and always I have to underlay. I had done overlay in few cases. I was became very bold, in surgery. Sometimes you say, oh wow, it's not chora, and then the next case, you have a failure. So now I don't do. I just do underlay.
Okay.
Thank you.
Do you find that the graft has moved, dislodged during your fluid air exchange, and do you think a visco would have kept it in place or a PFCL would have.
So that's a very good question because I had one patient where even underlay dislodged. So in that case, you can put visco on top. And then one patient I had to put autologous blood because I think Dr. Meena Chakravarti has described this technique for macular holes where she, in Retina Journal somewhere. So I just put a drop of blood on top. And I feel if you're finding when you're doing fluid exchange, if it's rolling or moving, then you can do any of these. It's a very good idea.
Autologous blood takes time for them to prepare. So we have to tell them before the surgery that we might
I
need
just
it.
I asked the anesthetist to take out the blood fresh. Then they take out the plunge of the needle. The sister takes it out in 1 ml, and then I just put the fresh blood on top. I don't do the fibrin and that.
Okay.
Yeah.
Okay.
I think it works fine.
Okay.
Yeah.
Great.
Okay.
Any other questions from the audience?
So we will conclude this session, and we'll thanks all the speakers and ASRS and AIOC for this opportunity. Thank you, ma'am.
Thank you. Thank you, everyone.
Thank you, Isha.
Thanks.